So today we have Dr. Marta Maslej with us. She's a staff scientist with the Krembil Centre for Neuroinformatics at the Centre for Addiction and Mental Health in Canada. And Marta is having a very interesting work at the moment. Her current research is involving using computational methods to derive insights from clinical data, including psychiatric notes, with the aim of improving assessment, informing treatment decisions, and identifying and mitigating bias, which all of you know this is so relevant. She is interested in human AI teaming as well, and the ways AI can supplement limitations in human cognition and prognostication to enhance psychiatric care. We are really looking forward to her talk today with us. So, Marta, whenever you feel free, you can start. Thank you so much.
Sure. Thanks so much for having me and inviting me to present. I'm really excited to talk about this work. So first, maybe I'll just share my screen. 1 second. Okay, so I think I'm sharing. If someone can just verbally confirm that they can see my slides.
Yeah, it looks good. We can see it.
Okay. Thank you. That's great. Okay, so today I'll talk a little bit about our research into AI and mental health equity, and what we think is a bit of a need to reimagine the future of clinical decision support, especially in mental health contexts where bias is a concern. And so, as Raquel mentioned, I'm a scientist at the Centre for Addiction and Mental Health, which is a psychiatric hospital in Toronto, Canada. And I co-lead my team with Dr. Laura Sickstrom, who's a medical anthropologist. We have a very interdisciplinary research team that studies applications of AI and mental health. I'll talk a bit more about the computational work today, but Laura does a lot of ethnographic work as well to complement what I'll be speaking about. And we do have a lot of collaborators on this work. One in particular is Dr. Juveria Zahir, who's the medical head of the emergency department at our institution. So just to say that we do collaborate with a lot of clinicians, and a lot of this work would not be possible without their contributions. So today my talk will have 3 parts, and in the first part I'll talk a little bit about how social and systemic forms of bias can become embedded in the data sets that are collected at our hospital. Then I'll move to talk a little bit about how training machine learning models on these data sets can lead to biased outcomes. And then at the end, I'll conclude with some of our research into human-computer interactions that examine how these kind of biased predictions can impact decision-making behaviors. I probably don't need to tell this group, you're probably all aware that over the past decade or so, there's been a ton of efforts to try to train machine learning models to predict different clinical outcomes. And one of the, maybe arguably the most prominent use cases, or one of the areas where people think AI might have the most promise in healthcare is in the area of oncology. And so there are a lot of, there's a lot of talk about the promise of using AI to, detect patterns in X-rays, to detect pathology in cancer care. But there is this growing body of research that is starting to suggest, not just in oncology, but other areas of healthcare, that AI predictions might differ based on the patient groups that they're being applied to. And so in the context of oncology, there's a really interesting study that came out a while back by Syed Kalantari and colleagues that basically showed that deep learning models trained to detect pathology using only chest X-ray data were more likely to underdiagnose pathology in certain patient groups, specifically Black and Hispanic women. And so it's often the case that, AI tends to disadvantage groups that are already structurally disadvantaged in some way or might be underserved by the health system. And so we have carried out similar kind of research to better understand what types of biases might exist in the data sets that are used to train machine learning models. specifically in the area of psychiatry, which is the context I work in. And we've looked at this question in the context of a very specific clinical challenge, which is managing risks of violence or aggression. So in acute psychiatric care, or when patients are hospitalized for psychiatric conditions, although it's rare, sometimes they do become violent or aggressive. And of course, this has very adverse outcomes for, providers and staff, but also other patients and institutions in general. One of the most effective ways of managing violence or aggression is simply by assessing patients for their risk of becoming violent or aggressive, because this can lead to more effective de-escalation and the application of timelier interventions, potentially ones that are less coercive than, these kind of last resort interventions like having to restrain a patient, excuse me, or put them into seclusion. But we're interested in violence risk assessment because of the potential for bias. So we know there's a lot of social stereotypes associated with who is likely to become violent or aggressive. And also these can be compounded by structural factors like barriers in accessing proper treatment and mental health care, other kind of social or environmental issues like inadequate access to housing or food insecurity. So we thought this was an interesting use case to explore in the context of bias. And at our hospital, CAMH, one of the most common ways that nurses assess patients for their risk of becoming violent or aggressive is using this structured rating scale called the Dynamic Appraisal of Situational Aggression, or the DASA. So every morning that a patient is on the unit, that when they're being hospitalized, patients use this DASA scale to assess them for their risk of becoming violent or aggressive over the next 24 hours. So nurses will kind of compile their observations about the patient, review any health record data that was compiled, including their clinical notes, and they will rate the patient on these 7 behavioral and interpersonal precursors to potential violence or aggression. And then so the score ranges from 0 to 7, and then it's parsed into these different risk categories, with any patients that are flagged as moderate or high risk for aggression or violence, potentially being kind of considered to be at risk. And so false negative assessments are very rare. So it is very rare that a patient will get rated as a low risk for aggression, and they actually become violent or aggressive. But of course, the DASA isn't a perfect tool. And so about a quarter of patients who are rated as high or moderate risk don't go on to become violent or aggressive. And so these are what we have sort of thought about as false positive assessments or incorrect risk assessments. And so we were interested in our research whether some patient groups might be kind of overrepresented in these false positive assessments, because although these false positive assessments might occur because of the interventions that are applied following the risk assessment, it shouldn't be the case that these false positive assessments are related to demographic factors that in theory should not be related to risk assessment, like someone's race or ethnicity. But we were also interested in exploring other factors that might be related to risk, like a patient's diagnosis, like their housing status, with a specific focus on whether patients might have unstable forms of housing or be unhoused. And then we were also interested in how patients were admitted. So in Ontario, which is the province where we're based, under the Ontario Mental Health Act, patients can be apprehended in the community by police for admission into psychiatric care. But of course, we also know this gets complicated because historically, there are instances of racial profiling by police in the community. So it might be the case that certain groups of patients defined by their race or ethnicity or sex might be more likely to be apprehended by police for admission into psychiatric care. And so we were interested in doing an analysis where we examined how these different socio-demographic factors might be associated with this false positive assessment on the data. And in our findings, we have found that racially marginalized patients are more likely to receive a false positive assessment on the DASA scale. So when you look at these unadjusted prevalence ratios in our models, you can see that patients that identify as Black, Indigenous, and Middle Eastern are more likely to receive a false positive assessment. But we were also interested in models that adjusted for other factors, like other demographic factors like age, gender, but also diagnosis, housing status, admission mode, and specifically whether patients were admitted by police. And when we do adjust for these other factors, which is shown in the adjusted prevalence ratios, these associations of race and false positive assessment tend to attenuate or disappear. And so, what are these other factors that are more strongly related to false positive assessment? Well, we find that police admission is a very strong predictor of false positive assessment, as well as having unstable forms of housing or being unhoused. And so what we think this means is that these associations of race and false positive assessment are maybe due to these more kind of structural or systemic factors like racial profiling in the community by police or more frequent admissions of racialized individuals by police into hospital. Them being more likely to have unstable forms of housing. And we know historically there is this construct of racial residential segregation and lower socioeconomic status. And potentially having more severe and treated mental illness, because we do find that more severe diagnoses are associated with false positive assessment. So really what we think this is starting to show is that, this bias in risk assessment isn't necessarily interpersonal, but it might start, before a patient even comes to the hospital with these more structural issues. I did want to mention some research we're doing now. So more recently, we've been trying to probe into what kinds of information in health records might be associated with risk assessment more broadly. And partly this is because we've finally gotten our hands on some clinical notes. So we were very interested in text data in the health record for many reasons. One mainly is that in psychiatric care, a lot of assessment and treatment happens via natural language. And of course, this gets documented via text in clinical notes. And so, for example, when it comes to risk assessment, nurses keep very detailed notes about patients throughout their shifts while the patients are on the unit. So they write something called the functional monitoring tool, or an FMT. And this is basically a clinical note that's written by nurses every couple of hours, which is just like a brief description of the patient's mental status, how they're feeling, what they're doing, what their attitudes are like, what their behaviors are like. And of course, these nursing shift notes can contain very important information about risk of violence or aggression. But we also know that the language that's used to describe patients in clinical notes can have very important consequences and can impact the way patients are perceived by providers. So there has been a lot of focus on the use of stigmatizing or non-person-centered language in clinical notes. So this is language that kind of reduces a patient to their symptoms and behaviors rather than considering the context. And so this can include things like calling a patient delusional or psychotic rather than saying that the patient is experiencing delusions or psychosis, or saying that a patient is aggressive or difficult or dangerous without providing context for these descriptions. And so there's been a lot of research that has looked at both the existence of stigmatizing or non-person-centered language in clinical notes, but also experimental work that has looked at the implications of exposing providers to stigmatizing language. And this research has shown that, if you expose a provider to the term calling a patient an addict, for example, as compared to a person with a substance use disorder, providers are less likely to want to treat the patient. And so this can have real implications for the way patients are treated by providers. And luckily at our institution at CAMH, there has been some research into stigmatizing language. And one of our colleagues has developed a lexicon of potentially stigmatizing or non-patient-centered terms, which we have then used to mine clinical notes. So this is ongoing research that we're doing now, and it takes a similar format to other work on the DASA. So basically what we've done is we've used the developed lexicons to mine the available clinical notes that we have. So for now, we only have a subset, but so that's what we've looked at. So it's a subset of notes from just under 2,000 patients. And then we've looked at the associations of the stigmatizing terms with the various risk assessment outcomes, specifically high or moderate risk assessments on the DASA, as well as these sort of false positive assessments that we've looked at in our prior work. And what this research is beginning to show, and as I said, it's still ongoing, so the findings are quite preliminary, is that there is appearing to be some signal in the clinical notes, specifically that the frequency of stigmatizing terms is associated with these false positive assessments, but not necessarily receiving high or moderate assessments on the data. And so essentially, we're seeing that more evidence of these stigmatizing and non-person-centered terms in notes written prior to false positive assessments may be influential. And this is especially important to think about because we are also finding more evidence of these stigmatizing and non-person-centered terms in the clinical or nursing notes of patients from specific socio-demographic groups. So specifically patients who are Black or Middle Eastern, but also as related to some of these more structural or systemic factors that I mentioned earlier, like patients who are in supportive housing or unhoused, patients with low income status, and those with low educational attainment. And so this is already starting to kind of point to a potential bias in the clinical notes, but we are currently investigating other language features that might be influential. And I did want to note that this isn't just research that we're finding in our own hospital, but there's been a lot of other work that has looked at the presence of stigmatizing and non-person-centered language in clinical notes from other institutions. So there's a really excellent paper written by Himmelstein and colleagues that was published in JAMA Network Open, which used a very similar lexicon to the one that we used. And they observed similar demographic disparities in the use of stigmatizing language in clinical notes. So it's worth a read if you get a chance. But I did want to mention an important caveat related to the use of lexicons for this type of research in that they are quite limited and context matters a lot. So as an example, clean is a word that appears in the stigmatizing lexicon, specifically in the context to when we're describing a patient having a negative drug screen. Sometimes that can be referred to as the patient being clean of a given substance. And this is considered stigmatizing because it sort of implies that if a patient is screening positive for a substance or a drug, this implies that they're dirty rather than clean. But of course, this can also be used in the context of a patient receiving clean sheets, which we've also seen in our clinical notes. Another example of this is if nurses use the word difficult to describe a patient. So we've heard from clinicians that if they see in the clinical note that a patient is described as a difficult patient, they sort of roll their eyes, they brace themselves to kind of approach that patient in a way that they're already expecting the patient to be difficult or negative. But of course, we've also seen in clinical notes the word difficult being used to describe someone's difficulty in securing housing, for example, which is not stigmatizing. And so one thing we're exploring right now is the potential of using these like generative AI models to pick up on the context behind the way these stigmatizing words are being used. but also their ability to pick up on more nuanced expressions of stigma in the health record. So a little while back, there was a paper that came out again, I think in JAMA Network Open by Park and colleagues, which was a qualitative analysis of stigmatizing language in clinical notes. And basically, they kind of analyzed clinical notes from health records and found these different categories of stigmatizing language that could have potentially negative implications for how patients are perceived, like language that questions the credibility of patients, language that's used to disapprove or moralize patients' decisions or behaviors, and other types of language. And so we're exploring the possibility with which generative AI can be used to pull out these more nuanced expressions of stigma. And we'd like to see if they're also related to risk assessment outcomes. So finally, I wanted to get to implications of machine learning, because I think that's sort of why we're all interested in this research is, what are the implications of training machine learning models on these sorts of biased data sets? And in the context of violence risk assessment, there have been many efforts to train machine learning models on data to predict whether or not a patient will become violent or aggressive. The most common data source for this research is health records, both structured and unstructured or text records. And there actually has been a systematic review and meta-analysis of this topic that basically found that machine learning can be helpful. There was a general trend toward better performance of these models compared to structured violence risk assessment instruments like the DASA. And I also want to note that this isn't just a research effort. So there are hospitals that are trying to develop and implement this sort of clinical decision support tools as well. So there's one hospital in Ontario, the province that we're in, called Waypoint, that is developing this sort of early warning system and with the hopes of implementing it. So it's not just like a theoretical research effort. It could become something that might one day be integrated into hospitals. So we wanted to better understand, what are the fairness implications of training these sorts of models on routinely collected data like health records. So we did this by training our own machine learning model on health records from our hospital. We took all the structured data that we could find about patients during their inpatient hospitalizations. This includes their risk assessment scores, but also their socio-demographic characteristics, their clinical characteristics, also information on how they were admitted and the nature of their admission. And then we basically, of course, we compiled a training and a test set. We tested a variety of models with different hyperparameters using 5-fold cross-validation on the training set. And then we kind of chose our model on the training set and the best performing model, and then we applied it to generate predictions on the test set. And we were interested in overall performance. Oh, sorry, and I should say that the model was trained to predict whether or not a patient would become violent or aggressive on a given day. And for prediction, we only used the first 3 days of the inpatient hospitalization because research suggests that most violent or aggressive incidents happen during that time when the patient is still being stabilized. So of course, this is like a binary classification task. So we were interested in examining the common kind of performance metrics, but we were most interested in fairness. So understanding performance disparities between sociodemographic groups. And in particular, we were interested in false positive rates or instances where patients were rated to be at risk of violence or aggression by the model, but they didn't go on to do so. And in terms of our performance, our model achieved an AUC of 0.81, which really maps on to what prior research has found in terms of the overall performance of these models. But it actually had very poor sensitivity. This is also not uncommon. A lot of models that are trained to predict violence or aggression don't show very good sensitivity in actually identifying who will become violent or aggressive, but they have pretty decent specificity. And actually, just for context, I did want to say that the DASA at our hospital, which is that structured rating scale, has a better sensitivity than the machine learning model. So we didn't find that sort of general trend that the meta-analysis reported to be true. But of course, we were interested in subgroup performance. So we wanted to see, in terms of overall performance, were there performance disparities between different demographic groups, such as those based on race or ethnicity? And if you look at the ROC curve, you can already see that there are these disparities in performance emerging for some groups. Some of them might be related to increased true positive rates, but some not. And then when it came to the false positive rates, we did find that false positive rates were higher among certain groups, such as racially marginalized groups, so patients identifying again as Black, Middle Eastern, or Indigenous relative to Asian, Indian, or white patients, but also for males, and especially the case for patients brought in by police, as compared to patients who just came in by themselves or with friends or family, and also patients who are in unstable forms of housing or patients who are unhoused. So again, we're seeing these performance disparities kind of come up in exactly the groups for which we were seeing biases in the data sets, which is probably not surprising. But I think the take home here is that, if you train machine learning models on potentially biased data, you'll get a biased prediction. And these are the sorts of disparities that are popping up in other healthcare areas, in other machine learning models trained to predict other clinical outcomes. And I should say that my colleague, who's a medical anthropologist, is doing a lot of work to sort of probe into these biases as well, consulting with a lot of different experts and groups to better understand, why, for example, we're seeing these biases with Middle Eastern groups, or why police presence at admission is such a big contributor to false positive assessments. So I wanted to just conclude by talking a little bit more about the implications of exposing providers to biased AI predictions, and sort of, how we can make it so that even though we have biased AI, which I think is inevitable, how do we make it so that the care we provide to patients is unbiased, or at least mitigated from bias? And I say this because one of the things I hear a lot as a solution to this issue is human in the loop or human oversight, clinical oversight, right? We hear a lot that anytime you develop machine learning applications in healthcare, it's a high stakes setting. So you need to have a human or provider in the loop that can kind of oversee the AI predictions and come to their own conclusion about what the decision is. In our case, for example, whether or not a patient will become violent or aggressive. And actually, this sort of guidance and is really codified in our guidance that's provided to physicians and healthcare providers by the Royal College of Physicians and Surgeons of Canada. So the guidance that they provide in their AI policy, or at least the most recent one that I read, was that employees who use AI are responsible for verifying the accuracy, truthfulness, and appropriateness of its content, and that employees should be especially vigilant in identifying any biased or discriminatory content and take steps to address such issues. So that makes sense. But I guess what we kind of were interested in understanding is will this human in the loop approach safeguard against biased AI recommendations? And so the way that we've looked at this is by running these experiments in human-computer interaction, which kind of ask people to make decisions based on very kind of artificial scenarios, and kind of monitor the impact of biased AI recommendations on their decision-making behaviors. So in this one particular study that we did, we had participants that were recruited via crowdsourcing to read these vignettes about people in the community and make decisions about the best course of action. So these are people experiencing mental health emergencies, and the participant in the study is asked to decide whether the person needs medical help, or if there's a risk of that person becoming violent or aggressive, whether police should be called. And the person in the study, or the person in the study, they're also given these AI recommendations. The key manipulations in these experiments are that the demographic identity of the individual experiencing the mental health emergency is manipulated in the scenario as being either Black or white, or other. We've experimented with other demographics as well. And then participants are assigned to different conditions in which the AI decision is either biased, so being more likely to call police when the person is depicted as being Black, or the participant may receive an unbiased recommendation where the decision to either call police or medical help doesn't depend on the demographic characteristics of the depicted individual. And so really the idea is to see, like, if we expose people to biased AI recommendations, will they make more biased decisions? And of course, maybe not, again, not surprisingly, we do find that people who are exposed to biased AI recommendations do make more biased decisions, in that they are much more likely to deploy police for Black individuals in the vignettes as compared to white individuals when they're in this biased AI condition as compared to the unbiased AI condition. And one thing that might be the case here is that in these experiments, first of all, they're very artificial. They're kind of human-computer interaction experiments that are conducted online. But the key thing here is that we are using crowdsourcing to recruit. So these are just people who are, on crowdsourcing platforms that are kind of paid to complete tasks and in some cases do research studies. So one of these platforms is, in the US, it's Amazon Mechanical Turk. Another platform that's commonly used is Prolific, which I believe has people in the UK as well. So we could just be seeing an effect of recruiting from these crowdsourcing platforms, but other researchers have found similar effects using these same types of vignettes and demographic manipulations and the same conditions in samples of healthcare providers as well. So this suggests that, experts or healthcare providers are not necessarily immune to these sorts of effects. One thing we were also interested in was seeing whether these design interventions that are meant to safeguard against biased AI would help at all in mitigating the impact of the biased AI recommendation. So a couple of years back, researchers investigated the impact of something they called cognitive forcing interventions. So these are kind of design interventions that are used for AI-supported decision-making that are intended to slow the process of decision-making. With the idea that, if you force people to think very deeply about the decision and the details of the decision, this might lead them to think more critically about the AI recommendation and rely on their own judgment, especially when AI is inaccurate or biased. And so we ran another study where we tried to test the impact of 3 of these types of cognitive forcing interventions. So one of them was an intervention where we delayed the AI recommendation. So we had participants read the vignette, then we asked them to wait 30 seconds before we showed them the AI recommendation, and then they were asked to make the decision. Now, 30 seconds might not seem like a long time, but for someone completing a study, it is a long time. So it sort of gave participants an opportunity to really reflect on the vignette. In another condition, we tested an update AI condition. So in this case, participants were asked to make their own decision first, and then they were shown the AI recommendation, and then they had the opportunity to update their decision following seeing the AI recommendation. And then we had another condition called AI on demand, where participants weren't shown the AI recommendation automatically, but they were asked if they would like to view the AI's recommendation. And if yes, then they were shown the recommendation. And so we really wanted to see whether any of these conditions would mitigate biased decision-making in the presence of biased AI recommendations relative to the control condition, which just showed the prescriptive AI recommendation right away. And we ended up finding that in none of these conditions relative to control, participants were any less likely to make a biased decision. So specifically a decision where they were more likely to deploy police for Black depicted individuals. And I mean, I don't know that this is that surprising, because of course, you know, if we have biased data and the data comes from human biases, social, structural biases, but really biases that are human in nature. So if we train AI models on these biased data sets, we'll get biased AI recommendations. So then when those recommendations are overseen by biased humans, this could still lead to biased decision making. And so some of this research is starting to question like whether human in the loop or having a clinician in the loop will really safeguard against biased AI. And so this kind of leads us to a challenge, right? Because, you know, in some cases, also putting the responsibility on overburdened frontline healthcare providers is also not fair, right? Like if we understand, at least in Canada and maybe the UK is the same, how, like frontline staff in hospitals, like nurses, social workers, are already very busy and stressed. And so if we put the responsibility on them to oversee AI recommendations, this kind of is an unfair burden that we're placing on healthcare providers. And so, you know, rather than developing these AI models that could be biased and then trying to find ways to redress those harms, either by human in the loop or even technical solutions to kind of fix the disparities in AI performance, we're sort of wondering whether it might be better to try to, at least in cases or contexts where bias is a concern, like violence risk prediction, can we implement AI solutions that actually redress the harms of a biased society? And so really, we're trying to look into different AI applications that might promote health equity. So rather than kind of relying on human in the loop, can we develop applications that will directly advance equitable outcomes for patients? So really, this is just like reimagining how we're going to use AI in these contexts where equity is a concern. And so I'll just quickly go over two potential applications of this. So these are two research projects that we've just gotten funded. So we're trying to kind of roll them out and do research into their impacts. So this project is called the FAIR Plus project, and it is led by Dr. Laura Sickstrom, who's my collaborator, who I mentioned earlier. And the idea here is that if we know that there are some patients that are at risk of receiving a biased risk assessment, maybe because they've been, you know, apprehended in the community by police due to being unhoused and maybe more kind of exposed in the community, and then they're brought into police or they're brought into the hospital by police, and then they're, you know, kind of unfairly assessed as being at high risk for aggression or violence, or maybe they're exhibiting behaviors or attitudes that are associated with violence or aggression and agitation because they are unhoused and underslept and food insecure, or maybe they belong to a racial or ethnic group where they have language barriers and there's a stigma associated with seeking mental health care, or there's culturally inadequate care, not availability of halal meals for some, or access to spiritual care. You know, all of these kind of different factors signal a need for patients rather than a risk necessarily. And so what Laura is looking at is whether, and we're collaborating on this project together, we're trying to understand whether we can generate an AI model that predicts patient needs that might then kind of be interpreted as precursors to violence or aggression, and a model that will provide more personalized and actionable strategies to address those needs. And so really the idea is, rather than generating a model that will predict a risk of violence or aggression, can we develop a model that will anticipate patient needs and provide healthcare providers and nurses with kind of insights on how to address those needs to better de-escalate patients. And then the other project that we're working on in this space is addressing this issue of stigmatizing language in health records. So I mentioned earlier that there are instances of stigmatizing or non-person-centered language in the health record at CAMH, and studies show that this language gets reproduced and perpetuated in health records at other hospitals as well. So it is an issue. But we also know that providers use this language as a medical shorthand, or sometimes this language gets used because there's a need for communication between providers and a need for documentation. But we also know that this language has negative consequences. And so, you know, as we all probably know, AI is really transforming clinical documentation with the onset of AI scribes. And so if we're going to use AI to produce clinical documentation, there could be a role for AI in mitigating the reproduction of stigmatizing language in AI-generated documentation in the health record. So the idea here is, can we prompt these generative AI models to write clinical notes that are not using these like stigmatizing or non-patient-centered terms? Because there's a lot of guidance out there on, how healthcare providers can use more inclusive, supportive, positive language that we can use to prompt AI. And so I'll just conclude with some takeaways here. So I think our investigations into the data that we're using are showing that there are these social and structural biases in clinical data sets, but it's not necessarily related to interpersonal bias. It's likely related to these more structural factors like the way patients are admitted, their housing situations, untreated and severe mental illness that's leading to this sort of bias that we're seeing in risk assessment data. Of course, like if we train models on these data sets, this could lead to biased predictions. But unfortunately, like clinical oversight or having a human in the loop is not going to be sufficient to mitigate biased AI. And so I wanted to just leave you with this quote from a paper that was written by my former postdoctoral advisor, who's an amazing researcher in this area, Marta Maslej. If you haven't invited her to speak, you should, because she does amazing work in this area. And she wrote this commentary that was published in NPJ Digital Medicine, where basically she argues that if machine learning has learned associations that we're not comfortable with, this provides us with an opportunity to raise the bar for accountability in medicine. And I think the idea here is that if we're going to use AI to transform our medical system, which we already are, this gives us an opportunity to really rethink the way we've done things and change them to promote equity. And so biased AI might actually be an opportunity for developing solutions that are equity-centered. And so with that, I just wanted to thank you for inviting me, to thank our funders. And my email address is here, and Laura's is here too, in case you have any questions for her. And happy to take any questions now as well. And so maybe
thanks very much, Marta.
Sharing.
Yeah. Thanks for the excellent talk. And yes, if anyone has any comment, any questions, please, they have some time now. Any comment, question? I have a question actually. You were accounting for bias and fairness, let's say, some fairness measures in your different studies. I was just wondering whether you tried some bias mitigation techniques, and what is your feeling about them?
Yeah, that's an excellent question. So yeah, there's like a lot of techniques that we can use to, mitigate the disparities in performance. So like, there's like adversarial learning where you like change the training data set. Of course, changing parameters, thinking about classification thresholds. And I think like I think they're important to try. And I would say the challenge there for me is I struggle with this because I worry that it's sort of this technical fix to this more social and systemic problem. And it's kind of the equivalent of trying to just like fix the model without fixing the larger issues that exist that are contributing to the model bias. So I would say, like, in this context, if you're a hospital and you insist on developing this type of model, at the very least, you do the fairness assessment and you apply these bias mitigation techniques, which I think could be effective. And so at the very least, you'll at least have a model that's not potentially exacerbating this inequity that already exists. Um, but I guess like, and so like some have asked us, have you tried like changing the classification thresholds, because it might just be the case that certain groups have a higher true positive rate and that's what's leading to a higher false positive rate. And that's probably the case. But I guess the question is like, why is it that certain racial or ethnic groups have a higher true positive rate in this context? What is leading some groups to be assessed at high risk for violence or aggression? And what is leading some groups to be more violent or aggressive in these contexts? And I don't think it's the race necessarily. It's of course these like social conditions that are leading to people being, racially discriminated, have inadequate housing, all the things that are hard to fix, right? And so I worry that some of these techniques might be just like kind of sweeping the problem under the rug and saying like, this isn't our problem because it's happening out there. It's policing, it's housing. And to some extent that's true. Like I feel very powerless about this sort of thing. Like we presented on this research and our hospital administrators are like, so what do we do? I'm like, I don't know. I don't have a solution. But I think this is where we might try to explore some of these like AI applications that will have the effect of directly advancing health equity as like an outcome itself, rather than trying to predict clinical outcomes, if that makes sense.
That makes total sense. Thank you for the answer, Marta. Is there any other question, comment from you? I think that Sarah has raised her hand, so please, Sarah, go ahead.
Hi. Yeah, thank you for a great talk. It was super interesting. I'm not completely sure what it is I want to ask, so bear with me while I try to organize my thoughts as I'm saying them. But I'm doing, or my group back in Denmark is doing really similar work. So this is particularly interesting to me, and I'm also like one of my supervisors have developed an algorithm trying to predict violence during psychiatric admissions, and I'm now trying to do some kind of fairness auditing across some of these models that we had developed. And I was just wondering, since actually we don't try to predict violence, we try to predict, for example, mechanical restraint, which is like one of the negative consequences of perceived violence, right? And I was just wondering, so when you try to predict these violence scores, which we have something similar, and you look at the higher false positive rate, I was just wondering whether you've also looked at whether there's a higher rate of, for example, restraint in these patients. Yeah, you're nodding.
Yeah, of course. Yeah. Absolutely. So, so there were two analyses that I described. So one, we were trying to look at high assessments on the rating scale, similar to the scores you might have in your data set, and trying to understand what are the factors that are associated with a high risk rating that's provided by a nurse, and then no documented violence or aggression following that. And then the second one is the machine learning model, which does something similar, but the scores are included as predictors. And then we see whether there's a violent or aggressive incident that actually occurs over the next 24 hours. Now, when we say violent or aggressive incident, what I should have mentioned is that mechanical restraints are included as an outcome, only because at our hospital, and probably at yours too, they're only used when there's like an imminent risk of violence or aggression. So that's included in our outcome. I don't believe we've looked at what happens when we exclude that from the outcome. So that's an interesting question. But there is also internal data at our hospital that shows that these same racial or ethnic groups, and especially Black patients, are more likely to be restrained. So it does complicate things, but in our research, we've typically included mechanical restraint because it's such a coercive outcome as a violent or aggressive incident.
Right. Yeah, because I was just thinking about the causal chain of it all, right? Because just getting a high risk score is not necessarily a bad thing, right? Depending on the intervention. So actually, we've been talking about what kind of measures are especially, or metrics are especially bad to have a big disparity, and we actually settled on false positives not being that. Because the intervention is in our case more attention, right? You're doing some extra like schemas and stuff, like more attention from the staff that should hopefully lower your chance. Of course, it's a whole different discussion whether the intended effect is the actual effect, but the idea is that it's a positive intervention. So if a minority group is receiving more false positives, then they're actually just receiving more attention, right? As long as they're not then also getting like restrained more. That would be the terrible part. Yeah. So I'm just wondering, I guess, these false positives for the risk scores, whether is it possible that it's because it's not because these patients are deemed more aggressive, but that they receive other interventions or interventions that actually subvert then the potential violence.
Yeah, absolutely. So like, it might be the case that, well, it's not might, it's probably the case that a patient, like a given patient will receive a high or moderate assessment. And then, they might receive some sort of interventions that then prevent an incident that otherwise would have occurred, I think is what you're saying, right?
Yeah, so it's kind of like a false positive.
Exactly.
Yeah,
that's right.
Yeah.
And while that's true, I guess the question is like, should it be the case that certain race or ethnic groups are more likely to receive those interventions that then lead to like a prevention of a violent or aggressive incident? And also, I guess like when you train a machine learning model on those scores, and then it's more likely to provide a false positive prediction. What we're trying to understand, like, what are the implications for fairness and equity of care? And so there is some evidence that suggests that some of the most important contributors to violent or aggressive incidents in inpatient psychiatric care are negative interactions between patients and staff. And so I guess the concern we have is like, if certain racial or ethnic groups and other demographic groups are more likely to get this high risk assessment, could this lead to staff being, and so this is research coming out of some of the qualitative work that my colleague is doing. Could it be that staff then are taking these interventions that are meant to protect them from the patient, like never seeing a patient alone, keeping the door open, asking them to keep space, stand back from the door, put my hair up in a ponytail, and just give off like more tension that then might lead the patient to kind of react in ways that are really hard to capture in these models, right? And so I think this is where qualitative research and ethnographic research becomes so key to be able to understand some of these like unquantifiable factors. But you're absolutely right. Like, it might be a false positive assessment. And so we've really struggled with how to describe this because we're really interested in incorrect assessment, but we didn't have enough false negative assessments to look at because that's such a rare phenomenon. So I think we're like, our groups are struggling with the same outcomes and how do we like best quantify this stuff? I don't think I have a good answer for you.
No, but that was a great answer. Thank you.
Thank you so much for the interesting discussion. I think it's now 3 minutes to 4, so we will finish the seminar for today. Marta, thanks for the excellent talk as well and an excellent job. And let's hope we can still keep connected. Thank you so much.
Yeah, very happy to keep connected, and thanks so much for inviting me. And if every other questions come up, just like email me. I'm around, so happy to chat.
Lovely. Thank you so much. And for the rest of the attendees, thanks very much for having joined today. And just telling you that the next seminar will be on 24th of June, when Igor Shujak, he's coming from the Columbia University, will be speaking about causal analysis of survival trajectories. We will hope to see you all again here. So thanks very much and enjoy the rest of the evening. See you soon. Bye-bye.